Well, good morning or good afternoon, everyone, and welcome to today's webinar. The webinar is brought to you by the Childhood Acute Illness and Nutrition Network, often known as CHAIN or the CHAIN Network, and the Global Health Network. Today, our topic is childhood mortality during and after acute illness, and we'll be hearing data and findings from the CHAIN cohort study that was conducted in sub-Saharan Africa and also South Asia. My name is Nigel Rollins, and I'm delighted to be joined today by several colleagues and friends who I'll mention in just a moment. I'm based at the World Health Organization in Geneva in Switzerland. I'm based in the Department of Maternal, Newborn, Child and Adolescent Health and Aging. Today we have several people who will share findings from the network, and I'm just going to very briefly mention their names. Many of them are doctors, but I'm not going to give titles. We have Epidemiology, who is one of the co-investigators from Malawi. We have Raza Izzat-Negadar from the Bill and Melinda Gates Foundation, who are generously supporting the entire initiative. Ezekiel Muperi, who is the principal investigator in Uganda. Ali Faisal Salim, the PI from Pakistan. Hamoud Ali, PI from Burkina Faso. Moses Ngari, who is one of the several statisticians for the network. Fakar Udin and Dr. Sassi Molyneux, who are social science researchers, will be sharing. Dr. Tamid Ahmed, who is the principal investigator in Bangladesh. Jay Berkeley and Judd Wilson, who are the co-PIs of the entire network. An old friend and colleague, Dr. Beatrice Amadi from the University of Zambia School of Medicine, and Zulfikar Bhutta, who many of you will know from the Hospital of Sick Children in Toronto, and also from the Aga Khan University in Pakistan. Today, we'll be hearing some of the clinicians' experiences from treating children with acute illness and malnutrition. We'll be hearing some of the quantitative and qualitative findings from the cohort study. Providing an overview of where CHAIN is now and probably thinking about where it's going to go in the future. And then we're going to conclude with a short panel discussion. And just very briefly, we have a little bit of housekeeping. Firstly, the session's being recorded. This recording will be shared in the coming days on the Global Health Nutrition or Network platform. And the materials can be found there using the link that's being shared just now in the chat box. To interact with the panel, please use the Q&A function where you can find in the toolbar. If you have any technical issues, please let us know in the chat, and the Global Health Network tech team will try to assist you. We have a dedicated time allocated for Q&A, and if we don't have time to address all your questions, we'll save them and try to share written responses along with the recordings. So just to get the day started and the program started, I would like to first welcome Dr. Emi Mbali, who is one of the co-investigators in Malawi, who's going to ask you some questions before we get into the main CHAIN findings.
Thank you. So we have two brief questions which we would like you to respond to, and these will be asked at the beginning, at the end. Could you please start by taking part in the poll, and you need to just connect on the poll section to give a response. The first question is, do well-nourished children have an increased risk of dying after hospital discharge compared to children in the community? We'd like you to respond to one, the one that you think is the right answer. So question A, response A, yes, they have a lot higher risk of dying. B, they have a slightly higher risk of dying. And C, no, a similar risk of dying. And D, they have a lower risk of dying. Please select from A to D the one answer that you think is correct. Right. The second question is, how long does an increased risk of dying amongst malnourished children after hospital discharge last? So option A, 2 weeks. Option B, 4 weeks. Option C, 6 weeks. And option D, at least 6 months. Over to you, Nigel. Everyone has had a chance to respond.
Right there, Emmy. And so we're going to keep you in suspense for those findings. and I suspect that some of the answers may become a little bit clearer through the course of the findings and the data being presented. We've got one very small change in the program, that Raza is going to share some of his comments after the presentations and after the findings, and just right before the panel discussion towards the latter part of the webinar. So without any further ado, I'm going to ask Ezekiel Mupere, who is the principal investigator for CHAIN in Uganda, to share some of the findings on clinicians' experiences. Over to you, Ezekiel. Over.
Yeah, thank you very much, Niger, and thank you very much, members. Briefly, those are my names: Ezekiel Mupere, pediatrician, medical epidemiologist based in Uganda. And I would love to share 2 points: the background of the site, and briefly the barriers to implementing pediatric inpatient care. Uganda is a country with over 42 million people, and 20%, which is approximately over 8 million children below 5 years. And among children, stunting and wasting is a major background problem. And over 2.5 million children are stunted, and over 650,000 children have child wasting. And the Malawi National Referral Hospital has been the main site, and the inpatient child load per day close to 300 children, and of these, about 3% die, and that was mainly at the time when CHAIN started. And among also other causes of under 5 mortality include the newborn, and among the newborn of the admissions, 20% had mortality, or commonly on a daily basis. And among other major common causes of mortality among the under 5, like any other developing country, include pneumonia, diarrheal diseases, malaria, malnutrition, among others. And prior to CHAIN study, we do not have systematic information as far as post-discharge mortality. And among the barriers to inpatient care at the time, and some of which have persisted up now, include high patient volumes versus low staffing levels, affecting on how a site can maintain standard of care daily or through the year. Also, inadequate supplies for drugs and other medical needs for managing child diseases, and also frequent stockouts, depending as the hospital is a government, depending on government resources. Further, it's a teaching national referral hospital, so it is affected by the characteristics of a teaching hospital, in which you have frequent turnover of intern doctors, postgraduate or resident students who need to have frequent orientation in understanding how to maintain care based on guidelines. So you have to have a robust system in a frequent training and orientation of the trainees. Further, infrastructure has been, at the time when CHAIN started, there was a lot of transitions and renovations to super specialized care. So a number of care for child services were put into limited space, or fragmentation of the ward. And this also affected not only patients who come in, but even those who have been admitted because of the need for transfer in terms of care. Similarly, support services such as laboratory, such as imaging, they were in different locations, and it was a challenge to be able to afford in terms of access to such care even within the hospital because of transporting very sick children. Further, we also had an issue of parallel services, particularly HIV care, which is in centers of excellence, leading to missed opportunities in terms of early identification and also continuity of HIV treatment and interventions. So those are among the key challenges or barriers, among others. Thank you. Over to you, Chair.
Thanks there, Ezekiel. And that really gives us a I think a very sharp reminder of some of the day-to-day realities that I think are probably present in all countries and in all settings, both for CHAIN and also for elsewhere. We're going to move on now and hear a little bit about some of the similar experiences and context from Ali Salim, who is the PI for CHAIN in Pakistan. Over to you, Ali Salim. And I think just to be aware that I think there's only one slide. There is no, don't expect slides to be changed here. This is just to give you a little bit of a flavor of the settings. Over to you.
Thank you, Nigel. And this is great. My name is Ali Faisal Salim, and I'm from Pakistan and site PI of Pakistan site. Just to give you an overview that we have done this study in the Karachi, which is the largest city of Pakistan and the 12th largest city in the world. The study site was Civil Hospital Karachi, which was over 1900 bed tertiary care hospital and the largest teaching city hospital in Karachi, and used to see more than 9,000 children monthly in the emergency room. The problem in terms of challenge of the healthcare system here is that private sector serves over 70% of the population in Pakistan. A majority of patients used to go to public sector and private sector hospitals. The quality of services and equalities varies greatly from the hospital to hospital. In Pakistan, infectious disease such as diarrhea and pneumonia are one of the most common cause of death and mortality, more than malnutrition. And 1 in 20 children in Pakistan die before the age of 5, and largely because of attributable diseases. We have issues in routine immunization coverage, and also we have overwhelmed public healthcare system. We have in all those sites, we have issues of high antibiotic use at primary care setting. The children used to come to the hospital are actually sick on arrival. In that time, the problem is actually following the guidelines, because the choice of antibiotics used to given in these children may be different. We have community level high extended spectrum beta-lactamase rate. The decision-making used to happen in Pakistan by the family members, particularly someone who actually running the cost or the services for the family. We have, as Ezekiel has mentioned, about shortage of trained healthcare staff. The public sector institute used to have inadequate medical supplies. And also there are always a concern of high density unit beds or ICU beds because of availability of beds, ventilators, and the staff. So in terms of, if I tell you about the gaps we have lack of follow-up the patient who actually discharged from the hospital. The concern about testing and treating these patients because they have financial burdens. We do not have health information management system in the public sector hospitals. Most of the public sector hospital used to have some breastfeeding counseling. However, the nutritional support and other were really missing. That's what I wanted to tell about pre-chain experiences we have. Over to you, Nigel.
Thanks, Ali Faisal. So we're starting to build up a bit of a picture of the settings where CHAIN has been implemented. And so we're going to hear one more sort of background or context. And this time we're hearing from Hamo Diallo, who is the principal investigator for CHAIN in Burkina Faso. Over to you, Hamo. We're not hearing you, Hamo. Can you just, I'm not sure if you're on mute. Maybe just try again.
Thank you, Nigel. Dear colleagues, I'm Hamad Diallo, and I'm professor of epidemiology and international health at University Joseph Kizerbo. This is in Ouagadougou, Burkina Faso. And I was the CHAIN PI for the Banfora site in this country. So first of all, let me give you an overview of Banfora Regional Referral Hospital. So this is located in the southern part of Burkina Faso. and serves as mainly a rural population of 900,000 people, among whose 17% are under 5 children. The area is endemic for malaria and has also a high prevalence of malnutrition, with 1/3 of children being stunted and 15% being underweight. Therefore, child mortality remain high in this region. I would even mention very high, with an under 5 mortality rate of 134 per 1,000. And communicable disease remain mainly the most common cause of postneonatal child death, with malaria, acute respiratory infection, and diarrheal disease being these 3 main causes. So the Department of Pediatrics is made of 4 units with 65 beds, an admission rate of 12 a day, and an overall facility death rate of 10%. Now, with regard to the challenge we made during the course of the chain, before the chain study, I would describe them into 4 groups. The first one being what I would cite as organizational challenge. And among those, I like to mention the absence of systematic clinical screening of children upon admission, whether for nutritional outcome or over clinical criteria of severity, although the ICMI guidelines from the Ministry of Health recommended. As a result, our staff did not make a clear distinction of children for death risk group. The second group of challenge I want to mention is what I would label as functional challenge, and those are really the group of challenge commonly met in other hospitals in Burkina Faso, and include a shortage of drugs such as antibiotics, antimalarials, but also consumables to diagnose or treat children, like rapid test diagnosis for malaria. And we had also missing very common materials such as, scales, infantometers, oximeters, or glycometers. So this is the second group. So the third group of challenge is really the most important one, and is linked to what I would call as routine management of admitted children. And among those, I would mention the poor communication with children parents, partly because some of them only spoke minor local dialect, while the staff used to speak French or the main local dialect, and also a poor communication with local facilities from which these children were sent. We also noted in this group of challenge the absence of systematic verbal autopsy, resulting in a measured real-time death rate, and the lack of systematic post-discharge follow-up, while some of our children came very far from this hospital, as far as 100 kilometers from Bafora. The last group of challenge relate to the data quality, and here I want to just mention the inaccurate and poor filling of form and registries upon admission, and the lack of reliable traces for each single child from admission to discharge, making it difficult to compute simple, reliable statistics on child death rate, and even on readmission rate, because we had no single ID for each of the child. So these were some of the challenges I wish to share with the audience, and I thank you for listening to me.
Thanks indeed there, Hama. So we've had the chance to really get a good sense of the context in which the cohorts are located. And we're going to now start hearing a little bit more about the epidemiology and some of the other clinical findings. And I'm going to pass over to Jay, who is the co-PI for the entire initiative, and also Moses, who is one of the statisticians working on the chain data sets. Over to you, Jay and Moses. And maybe just before starting, again, just to remind you, please, if you have any questions, put them in the Q&A function or in the chat, okay? And we'll try to get back to that. All the best.
Great, thank you for joining us today. I'm going to do a split talk together with Moses Ngari, who was the senior statistician on the Chain Network project, and we're going to tell you about the design and some of the epidemiological results from the network. The problem that we were trying to tackle really is that despite an overall reduction in child mortality worldwide, we still see very high risks of death in children who with acute illnesses. And there's growing awareness that there's a problem with post-discharge mortality, but the studies done up to now have been varying designs, duration of follow-up, and groups included. We know that anthropometry, simple things like weight for height, weight for age, mid-upper arm circumference are quite good predictors of mortality. They don't tell us much about the mechanisms driving the mortality. And thirdly, we are aware that the guidelines, such as the WHO guidelines and the national treatment guidelines in different countries, tend to focus on individual syndromes and short-term interventions. And Chain very much sees the issue of mortality occurring both in hospital and after discharge as likely to be related to the long-term health trajectory of children. And so we've questioned whether short-term interventions would necessarily be the most effective for reducing overall mortality. The Chain network itself was set up initially as a cohort with the idea of exploring the pathways leading to death amongst children who are admitted to hospital with acute illness. We wanted to understand better the epidemiology of mortality, and we did that through studying the clinical, nutritional, and demographic exposures, including things going on in the household and things about the child's carers. The second arm to Chain is the social science, and that you will hear about immediately after this talk. And there's a third arm to Chain, which is a systems biology study, looking at biological mechanisms which are leading to mortality and could lead to interventions. We supported sites to, as far as they could, provide treatment according to their own national guidelines and WHO guidelines. I'd say that we did well in this. We probably didn't reach quite 100% concordance, but it was very close to that, given the facilities available. And overall, we were after results which would lead to actionable interventions. Unlike the other big networks which have been supported, for example, by the Gates Foundation, this network was actually based in a low and middle income country in Kenya, where we ran all the coordination, data management, analysis, and everything else, with the other coordinating sites in University of Washington and also in Toronto. So I'm going to pass over to Moses Ngari, who will tell us a little bit about the design and then some of the initial results, and then I'll come back in.
Thank you so much, Jay. So I'm going to talk about design and discuss some epidemiological results. So the Chain study was a stratified cohort study recruiting children aged 2 to 23 months. Who were admitted in hospital. During the hospitalization phase, we collected daily observation data until the date of discharge. And upon discharge, we escorted the children home to collect some social demographic at household level, including the GPS, which enabled us to compute distance to the nearest health facility. We followed the children at day 45 after discharge, day 90, and day 180. In addition to the epidemiological results that we're going to present today, we also collected data, a lot of biological samples, social science, and other substances that will be provided later on. Next. The study was conducted in different settings, as you can be able to see, across 9 hospitals in 6 countries in Southern Asia, Bangladesh, and Pakistan, and Africa, both rural and urban, as you can see in the photos. Next. We collected comprehensive data, and these are some of the sample case report form that we used, including clinical, socioeconomic data, maternal mental health, as is shown there, from the date of admission up to 180 days after discharge from index admission. Overall, we recruited 3,101 children who were admitted in hospital. Among these, 1,218 were severely wasted or unquestionable. 763 were moderately wasted. 1,102 were not wasted. And we followed them after discharge for a period of 180 days. And during this follow-up, 116 or 3.7% were lost to follow-up. And so these are baseline data on data collected at the time of admission to hospital, and they were what you would see in a typical hospital in low and middle income countries. However, what was striking was the similarity across the three strata. If you see, for example, the leading cause of admission were pneumonia and diarrhea, regardless of whether a child was admitted, not wasted, moderately wasted, or severely wasted. The characteristics was fairly similar across the three groups. Overall, during the 180 days of follow-up, we observed 350 deaths, and as expected, the risk of death was highest among the severely wasted or partial group, where 20% of them died. Among the moderately wasted, 8.1 died, and among the not wasted, only 3.5 of them died, and this is from index admission up to 180 days post-discharge. So we include some of the deaths that occurred during the index admission. Looking at the mortality cumulative curve, we see actually we can be able to see there are two phases of the risk of death. The very early deaths on death that occurred immediately after hospital admission, the curve was very steep, suggesting that the risk usually is very high during the first few days of admission, actually a few hours of admission. And after that, the curve suggests that actually the risk does not end after that phase, but these children continue to be at risk, although the curve is not that vertical. It just suggests that the risk extends beyond the initial phase, or actually the admission phase. And again, this cut across the three groups, regardless of whether you're moderately wasted or severely wasted. The first few hours or first few days, the risk is very high. Then it starts going down, but still you're at risk even after discharge from hospital. Again, we looked at the proportion of death that occurred during index admission and after discharge. And among the 350 deaths that occurred, the ratio was actually 1:1. 48% of them occurred after discharge, while 52% occurred. And this was conserved across the three groups. So the test of heterogeneity, the p-value of 0.85, meaning that whether you are wasted, moderately wasted, or severely wasted, for every one death that you observed during inpatient phase, there was another one death after discharge when children released to go home. Again, among now the 168 deaths that occurred post-discharge, the risk of dying was actually higher among the risk of dying at home. So these are children that died without coming back or seeking a health care in a health facility, was higher among the severely wasted group. As you can see, 65% of them died at home, compared to only 41% that died among the not wasted at home. And this was significantly across the three groups. So I think I'll hand over to Jay to continue with the structural equation modeling results and discussion. Thank you.
Thank you, Moses. And I'd like to acknowledge Daniela Browse, who did much of this structural equation modeling. What I'm showing you here is a structure very similar to the the UNICEF causal framework for mortality in relation to childhood undernutrition. There's been a number of versions of this, and it's changed again recently. But what we did was we aimed to capture the essence of that framework, and we formed this framework before we did the analysis. So these are a priori groupings of elements of risk. If you look at the bottom, we have the pre-existing characteristics at the bottom. So there's HIV, underlying medical conditions in the child, nutritional risk exposures, including dietary diversity, food security and stunting, adverse caregiver characteristics, including mental and physical health and employment and other maternal factors, pregnancy. There's household level risk exposures, including water sanitation, asset index and location. Then finally, there's access to healthcare. In the middle row, we have the nutritional status in the brown color and the severity of illness in the blue color. And not surprisingly, both nutritional status and severity of illness are directly associated with mortality. And we see some of the pre-existing characteristics as directly associated with mortality. So for example, HIV on this left side, reduced access to healthcare on the right side, leading directly to mortality within 30 days. And likewise, the pre-existing characteristics along the middle also have a direct effect. And when I say that they have a direct effect, what that means is that none of that part of the effect is not captured by measuring nutritional strata or measuring the severity of illness. So, for example, when we look at the three underlying categories on the left, HIV, underlying medical conditions, and child-level nutritional risk factors, those some of their risk operates through the lower nutritional status. So some of their risk of mortality operates that way, which means that when you measure the weight for height, weight for age, or mid-upper arm circumference, for example, you're capturing these risks. But these risks also have a direct effect, which you would not be capturing by measuring nutritional status. Notice that none of these lead to the severity of illness, and I think that this reflects the selection of sick children being admitted to hospital. So this is a product of the study design. We also see an arrow going from nutritional status to severity of illness, which in fact has a minus sign beside it. And what that means is that there was a lower severity of illness observed in the children who were more malnourished, which may mean a lower threshold for admission amongst malnourished children, even though, as Moses said, they had very similar range of clinical syndromes between diarrhea, pneumonia, malaria, etc. That was for the 30-day mortality, and the second analysis we did was for 180-day post-discharge mortality. Now this diagram gets quite complicated, so I've actually left the bottom line of the pre-existing characteristics off this slide because you've seen them already. But what we have here is at the bottom of this is the same two characteristics at admission, the nutritional status and the severity of illness. But now we have another layer, which is events which are occurring around the time of discharge. We have the discharge nutritional status on the left, and we have the discharge signs of illness severity on the right. And in the middle, we have the duration of the admission, and we have the discharged against medical advice. And what we see here, not surprisingly, discharge against medical advice has a direct association with mortality, and also has an association with signs of illness severity. So if you're discharged early, you'll often still have some severity signs. We see a lot of arrows heading towards the box for the duration of admission, but we did not find an association between duration of admission and post-discharge mortality. And we think this means that simply that once the child's been decided that they should go home, then there may not be a strong rationale for keeping that child in hospital for longer. There are risks for keeping a child in hospital for longer. As in the 30-day model, we also see from those hidden bottom pre-existing characteristics, lots of arrows coming up to with those direct relationships with post-discharge mortality, specifically HIV, which is not surprising, underlying conditions, which is not surprising, nutritional strata, and caregiver characteristics. So the caregiver characteristics had a direct association with mortality in the first 30 days and also for post-discharge mortality. And there were two components to the caregiver characteristics domain. One was caregiver mental health, which was evaluated by the PHQ-9 score, and the other one was maternal employment. So that meant direct access to paid employment. And those were the dominant variables within the caregiver characteristics domain. So putting all this together, what do we think this means? Firstly, there have been previous reports on post-discharge mortality, some of which have suggested that the one death in hospital, one death after discharge, that sort of 50-50 relationship could be possible. And essentially, we've confirmed that finding across numerous sites. What we observed is that there are also many children with very low risk of mortality. And so we regard the way forward to be introducing an increased level of risk stratification. And for example, if admissions were, as well as being managed by syndromes, were risk stratified at admission, we would be able to take low risk admissions in the green box along the top, and devise guidelines for their early review and early discharge in much the same way as is done in pediatric observation wards in bigger hospitals. However, there are no specific guidelines at the moment for that, and that those decisions are often being made by staff with limited pediatric training. And so we would aim to move forward and try and develop those structures and investigate the safety of early discharge and freeing up resources for the care of higher risk children. For the high risk children, we believe that we need to implement some enhanced inpatient care, but in particular, we need a discharge evaluation, and that includes understanding the household to which and the carer to which that child is going back to. And that would lead us to conduct some studies of post-discharge interventions. And from our results, both from the quantitative work that I've presented and from the qualitative work, which you will hear about next, we believe that there are things like a virtual ward system where we could continue to track the progress of children using phone or short messaging service, facilitated access to hospital if the child becomes sick, psychosocial support and financial support may become important factors in post-discharge analysis. We are also doing a nested case cohort study, as I mentioned right at the beginning, using the biological samples collected during change. This is still ongoing, and we'll be presenting results of this in the future. We're involving a whole range of leading labs with a lot of omics and other kinds of analyses, and this hopefully will lead us to some specific biological interventions. So in conclusion, we see that anthropometry in these children is capturing risks beside their nutritional intake. We believe that we need to move to a more child-centered, risk-stratified approach to both inpatient and post-discharge care. We think that there is a large population of low-risk children who could be discharged earlier, which maybe reduces their own risk of hospital-acquired infection and antibiotic resistance, but certainly would reduce costs and resources, which could be then applied to higher risk children. We noticed that health professionals and families are often regarding children as recovered when they're discharged from hospital. But as we saw in Moses' data, we have a significant amount of mortality yet to happen. While we're good at up-referring from clinics and health centres up to the secondary or tertiary level hospitals, what we're not currently good at the moment is down referral. So down referral to the specific responsibility of an individual or clinic, like a health visitor model, which could be implemented to improve post-discharge outcomes. Our experience was that individual clinics like HIV clinics or nutrition clinics did not generally meet the overall health needs of children. And this is finally the website, www.chainnetwork.org. this is all in process of publication, and a preprint is now currently available at this site, and we can pop that address in the chat for you to look at. Thank you.
Thanks very much there, Jay and Moses. That was great. I know that people will probably have many questions immediately, but we're going to go straight on to hear from Fakar Uddin and Sassi Molyneux about some of the social sciences results. And after that, we'll just have we'll be starting to ponder and reflect on some of the findings. So over to you for this next presentation.
Thanks very much. So Udin and I are presenting on behalf of a far bigger social science and empirical ethics team. And you can see many of them in that photograph there. Of course, we're all part of the CHAIN study, but we're also, many of us, also part of REACH, which is a Wellcome Trust funded collaborative award led by Maureen Kelly. And the aim is to understand and strengthen resilience, empowerment and advocacy in women and children's health research of that REACH work. And actually CHAIN is one of 6 case studies that forms part of REACH. So we're going to be sharing some of the qualitative work that we've collected, and we're focusing on vulnerability and agency across treatment-seeking journeys experienced by family members of children. And we're interested in this because of the implications for interventions to improve outcomes post-discharge from hospital, but also, and we'll touch on this very briefly at the end, there are implications for support processes for frontline staff. Next slide, please. So the qualitative work was conducted in 4 of the CHAIN sites, 2 in Bangladesh and 2 in Kenya, 1 rural and 1 urban in each country. In each of these sites, we conducted interviews and observations with health workers and research staff. We interviewed community representatives, and at the heart of our work were repeat interviews with family members of CHAIN children in the homes of those family members to try to understand the whole treatment-seeking pathway and journey from the point of view, of those family members. Next slide, please. And so what we have across that data is 64 really rich and moving stories from a wide range of different family members. Next slide, please. Looking across all of those stories, what we can see is that the treatment-seeking journeys that family members and often mothers followed were complex and lengthy. So each of these rows in this slide shows one household, the number of actions over what time period before admission, the length of admission, and the number of actions and over what period post-admission. And so what we can see is that there's many actions that are being taken by mothers, and many times they're struggling with a whole range of different challenging socioeconomic contexts. Looking across these journeys in more detail, what we can see is that there's a range of potential issues pre-admission to hospital, during admission, and post-discharge, with implications for interventions and outcomes. Udin is going to talk to us about some of those issues in the next few slides. So next slide, please, and over to you, Udin.
Thank you, Shashi, and welcome all. As the whole treatment-seeking journeys is very interesting. Firstly, I am talking about identified key issues that influenced pre-hospitalization illness and treatment-seeking journeys of children in Kenya and Bangladesh. We have seen complex treatment-seeking and decision-making patterns that contributed to delays in arriving at the hospital, which has perceived eventual effects on poor outcome of children before and during hospitalization and even after hospital discharge. Our study revealed that carers, usually mothers, make huge efforts for child health and well-being. But unfortunately, mothers are often being blamed by other family members for illness of the child. Furthermore, pre-admission treatment-seeking actions were influenced by family members' understanding of the illness problem, relationship among parents, trying to minimize cost in the context of basic livelihood challenges. All these challenges are very much gendered, whereas gender, power, roles, relation, negotiation shapes parents' treatment-related decision-making and actions. For example, one Kenyan mother said, "It happens the blame. Sometimes we used to disagree because the father always claims that I do not cook proper food for the child, and that is why she feels sick. But the problem is when I cook, the child does not eat. At times, I ask him to feed the baby himself so that he can see what a poor feeder she is. But he will try and claim that he does not know how to feed the child. So it is my responsibility to feed her." This statement reflects pre-hospitalization vulnerability of children. Now let's see what happens during hospitalization of children. Next slide, please. We identified key worries of parents during admission, which influenced to discharge their children against medical advice. During admission, parents were concerned about direct and indirect cost for buying food and additional medicine from outside of the hospital, women's disruption in doing regular household responsibilities for staying long time in the hospital, which are gendered, as well as parents worried about child's progress and quality of care and food receiving from the hospital. And finally, disrespectful comments from others that carers are staying in the hospital long time just for getting free food. Now let's see the key issues that influence post-hospital discharge adherence to medical advice and treatment seeking guidance. Next slide, please. Inadequate and misunderstood communication between carers and health workers had perceived eventual effects on adherence to medical advice post-discharge, as parents did not know where they need to go if a child again suffer from illness and deteriorate illness condition post-discharge, or what need to do for recovery of illness and improve nutritional status, as well as why particular care is important even if the child looks well after hospital discharge. Some parents wanted to follow hospital clinicians' advice post-discharge, but unavailability and unaffordability of households, carers back to the basic same livelihood and gender-related challenges with additional post-discharge burden created barrier for providing recommended therapies, food, medicine, and ensure clinical follow-up post-hospital discharge. For instance, due to intimate partner violence, one Bangladeshi mother said, "I am really reluctant to provide medicine and food in time as per hospital physician advice." These statements indicate that how young underage children are vulnerable after hospital discharge, which finally increase perceived risk of undernutrition, morbidity, and mortality among young children post-discharge. Now I am requesting Shashi to continue remaining presentation. So over to you, Shashi. Thank you.
Thanks, Udin. Next slide, please. Thanks. So what we can see across all of those often extremely moving stories is that caregivers, often mothers, are exhibiting lots of agency in terms of seeking out and acting on advice, implementing all kinds of strategies to try to keep costs low and to minimize costs. But this agency is very much constrained by a whole range of different structural and situational vulnerabilities. Just a few of these are highlighted on the right-hand side of the slide, but they include hunger and financial challenges. Something that's not been mentioned in Udin's slides was that the mothers themselves are often unwell. And as Udin did highlight, there's a lot of descriptions across stories of family members feeling that they're being treated disrespectfully in facilities. And that's leading to concerns about the quality of care that's being offered and to delays in seeking care at those facilities, together with other vulnerabilities. Next slide, please. And the more immediate vulnerabilities that we're seeing are very much shaped by deeper structural drivers of many different forms, including socioeconomic, political and cultural, but also significant resource constraints in the health systems that they're trying to deal with. Next slide, please. So obviously, given these stories, Magic bullet single interventions are not going to be possible. And as Jay has already highlighted, a series of different interventions, even those targeting health facilities and initiated at health facilities, might best be targeted towards particularly vulnerable patients, and that some form of screening tool might be useful to identifying those family members and children that need greater support. This is in addition to deeper structural interventions that are needed. And it's important that these interventions are co-designed with managers, participants, and implementers in order to reduce the possibility of unintended consequences in the short and long term, and making sure that they don't add to gender inequities. So next slide, and then on to the final slide. So ethics dilemmas are also confronted by the frontline staff who have to interact with vulnerable families. And this can be read more about in this paper that we've published on ethics reflection sessions that we introduced into Chain. And last slide, please. In order to access these materials, including a series of publications, please do visit these two websites for Chain and Reach. Thank you.
Many thanks indeed there to both you and Sassy for that. We're going to just jump and change the program very slightly because Professor Zulfikar Bhutta has a hard stop in a few minutes, and we wanted to get some perspective and thoughts from Zulfi ahead of leaving the webinar. So without further ado, Zulfi, over to you for just some reflections and any questions that you might want to present to any of the groups. Over to you.
So thanks very much, Nigel, and thank you, Jay and Sassy, for this fascinating presentation, and to the other chain investigators. I look forward to seeing the paper finally published in a couple of weeks. And as I reflect upon it, I mean, one is reminded time and time again how important the social determinants of health are, not only in understanding the context of genesis of illness in families and children, but also in how families recover, or sometimes, as is the case in this particular analysis, not recover from that experience. The findings from this large multi-country study, systematic review of what happens to children who are admitted to hospital for acute illness, corroborate previous data as well. Some of these findings are very similar to what was observed in the Global Enterics GEMS study, with excess mortality documented for up to 2 months, if I recall exactly, 8 to 12 folds higher mortality in those who were discharged from hospital, and without necessarily a gradient by nutritional status. 3 things that I reflect on, and then I have a specific question of you. So one is really the interface of maternal health and child health. And as was underlined in many of your own findings, the status of women, and particularly the whole experience of women in the context of gender-based domestic violence and the relationship, and although it was not highlighted here, between the mother and the mother-in-law in joint family systems, as is the case in many parts of Asia. I mean, those are very important dynamics in terms of what happens in these circumstances. And one unrecognized subcategory at access risk is really the category in relation to maternal mental illness and mental health. The second, of course, is the all-encompassing role of poverty. And therefore, as you highlighted, importantly, it's not just enough to give medications or to give vaccines. I mean, for severe extreme poverty, where people have to make a choice between buying drugs or buying food, it is very important to also underscore how poverty alleviation strategies can interrelate with what we have from the biomedical model. And the last thing that I think your data very strongly suggest is the importance of outreach. That it's not just enough to have hospitals and hospital-based care. There are links with some form of outreach and community-based strategies, whether it's through community health workers or volunteers, or some other forms of linkages between the facilities and communities is extremely important. And our experience in work over the years in rural Pakistan indicates the same. In one large project that we have recently evaluated in 14 districts, it's very clear that there are sub-district differentials in mortality, which are very much related to, as you are finding, access to facilities, distance, and a host of other socioeconomic variables. The question that I have for you is, if you have been able to assess to some extent the whole role of severity of illness in relation to immunostimulation, or the ability of the child to mount an immune response. One of the things that we were not very clear and able to unravel in previous studies, including GEMS, was there a subgroup of children who, irrespective of nutritional status or an early, let's say, deviation of growth based on their intrauterine growth, was there a subgroup of children who were just not able to mount a sufficiently robust immune response to a range of systemic insults, including malaria, respiratory infections, diarrheal infections? Are there data within the chain network that allow us to unravel some of that risk categorization, which may not be discernible by clinical criteria? Thank you.
Thanks there, Zulfi. And maybe just before, I know you've got to drop off, but maybe Jay has his hand up and he may just be able to give a very quick response to that last one.
Yes, so we did do an immunology sub-study within CHAIN, which will be presenting separately, and certainly we were looking at the ability of children to respond to pathogens, looking at the whole blood responses to TLR receptor agonists, and also we looked at neutrophil function and inflammation. So all that will be coming out, and definitely we are seeing some abnormalities, certainly in innate immune function. The other really interesting thing is that we tend to think of malnourished children as somehow immunosuppressed, but in fact, these children are on fire. They're in a hyperinflammatory status, and that seems to persist well after discharge.
Thank you, Jay. That would be really fascinating to see. As you recall, we had some very interesting dysenteric and non-dysenteric differences in mortality in the GEM study, and therefore I look forward to some of your data very, very eagerly. Thank you very much for this fascinating presentation. Congratulations for pushing the entire body of knowledge forward in reducing child mortality globally. Much appreciated. Thank you.
Thanks, Zulfi, for your time and for both the observations and also the question. I'm sure they will mirror many people's sort of perspectives as well. We're going to just take another small moment, just that Raza was not able to join us a little bit earlier, and Raza is within the Bill and Melinda Gates Foundation, has been very involved with kind of the excitement and sort of the support for CHAIN over many years now. And just as we're getting these sorts of perspectives, maybe Raza, you could just take a few minutes and give us just a little bit of the sort of the feelings and the thoughts from the foundation. Over to you for.
Thank you, Nigel. I appreciate that. Thank you, Judd, Jay, Sasi, Zulfi, other presenters that came earlier. It's excellent to see all of this come together in one flow, and a testament to all of the work that has been done over the years. In particular, when we started on this journey at the beginning, it was very unclear what exactly was the underlying driver of vulnerability in this population. There was, of course, previous work, as Zulfi had alluded to as well, that showed the importance of understanding the population, the difference in context.
So I can see, Raza, that we're needing to get a little bit of additional input there.
Sorry,
there's another opinion in the background, is there?
The difference, apologies for that. The difference in context, and at that time, what we were doing is just trying to understand whether we go directly into interventions. And that was really without a sufficient understanding of the population and what was going on and what would be actually an approach that could work. The CHAIN work and how it's come together, particularly as Jay presented the different patterns of illness, the different connections between household morbidity, household stability, as well as the underlying undernutrition itself, has really pushed the boundaries in terms of our understanding of what this population's needs are and what their illness course is, what goes on for them in the hospital setting, what goes on in them afterwards, and what approaches we'll need to take in order to be successful. Having watched this over the course of the past 5 years unfold, we've gone from an understanding that was quite limited in terms of where to intervene to a richness of data, not only at the extremes of omics to understanding this population, but really capturing some of these dynamics that are critical to how we have an impact. Now, many have said the population itself is changing over time, and that's very much true. It contributes to the residual mortality that we see globally, and not having had this level of understanding of the heterogeneity across contexts would mean that we just take a one-size-fits-all approach. So in terms of the impact that the investigators have had on the foundation in terms of defining our strategies, defining the programs, and hopefully with a list of publications coming out, defining the field of global health, I think this is an immense undertaking and one that has been very successful to date. So I applaud everybody involved. I'll just end by saying one of the unique features of CHAIN has been the degree to which the sites have been engaged in the work, particularly from the view of investigators understanding the local context and getting involved with the research from a local perspective. That has been critical and is one of the challenges that global health faces when undertaking large efforts like this. I think it's been well addressed here, and yet there's ongoing work to do, how we continue to look at the richness of the data that comes forward and continue to allow that to open up training opportunities for other investigators locally is one aspect of CHAIN that there's been commitment to from the beginning that I remain very excited about. So I'll just end there with my gratitude. Thank you, Nigel, and to the CHAIN team.
Thanks there, Raza. We're going to actually, I think it's a very good moment to transition over and ask Tamid and Judd, who've been very thoughtful in the whole design and sort of concept as well as the implementation of CHAIN, just to give us a bit of a sense of where CHAIN is at the moment. And I'm sure you're going to allude a little bit, Judd, to where things might go to in the future. Over to you and Tamid.
Wonderful. Tamid, do we have you here with us?
Yes, Judd, I'm here listening very intently. Please go ahead.
Okay, well, thank you. I was going to say the same for you, but I will go ahead. So where are we now with CHAIN? Well, you know, here we are, I think, finally able to present the first of what I hope will be many presentations of the data coming from CHAIN. As you heard from Jay earlier, there's a large scale effort now working with multiple laboratories around the globe, really, to pull together all this systems biological analysis to try to understand the pathways, the biological pathways underpinning these mechanisms that lead to mortality. And the hope there is that we'll be able to then identify intervenable pathways where we can try to move forward into interventional trials. You've seen the results of the completed cohort, but even within that large, immense amount of data, there are a number of analyses that will continue to come forward. And one of the things I really want to highlight to this community and all of you on this call is that really there is so much information available, and we look forward to collaborating with many of you to continue to analyze these data as we move forward. The nested case cohort analysis with the systems biology, we expect the first results of those within the next 2 months. Most of the data for that are now in the hands of the Stanford team, who's really conducting the primary part of that analysis. And then each of the individual labs is doing additional work with the data that are coming out of those individual sets of data that Jay talked about in his presentation. I think what's notable, and Rasa alluded to this a little bit, is that we've really developed an incredibly collaborative family across the network amongst all of the PIs and the teams within the countries in which CHAIN has participation. And these sites have worked together collaboratively to develop a platform that I think is very robust, We have shared data, data capture systems. We've shared all of the SOPs and the trainings, and everything has been done in a really harmonized way that I think now is an incredibly robust platform for future studies and ultimately for these interventional trials. And we've now begun that process with initiation of the first trial within the CHAIN network, which is a trial of pancreatic enzymes and bile acid replacement, which is ongoing now. Recruitment is going on, and that's really exciting. And we have another trial in the sort of later stages of planning now, which we hope to initiate early in the next year of B. infantis strains in this population to reduce mortality and improve growth. We are also working closely with Nigel and with the teams at WHO within a risk stratification working group, which really is thinking much more clearly around this concept of risk stratification, what this means in terms of global guidance around the management of these high-risk groups, but also importantly, as was highlighted earlier, in addition to being able to identify and target these very high-risk groups, we also find a large group of children at very low to negligible risk. And there may be better ways to approach those children to both reduce their risk and also reduce the burden on the health system. And so that's really exciting work. I also want to point out that we've been working with the gender equity team at the Gates Foundation to really expand quite a lot of the social science work that you heard about, both for gender specific work that focuses on gender as an outcome in improving gender inequities, but also thinking about gender as an exposure and what are all of these gendered issues that are affecting families to have outcomes to impact negative outcomes on children and mothers. And so this is ultimately, we hope, going to culminate in a large multi-component randomized trial, which we're discussing now, both with the foundation and have also been submitting to other grant sources and moving that forward. And we think that, ultimately, this is the way that CHAIN is going to continue to evolve and continuing to be able to provide value to the community. We think that in the next iteration of CHAIN, if you wish, we really are intentionally looking to transfer more resources, more power to the sites and let more of the focus of control be with PIs at the individual sites as we continue to expand the ability of the network to be shared across the entire platform. And we also think that another area that's really important is to think about how we expand capacity across all of the CHAIN network to do trials that are more focused on product development and ultimately commercialization, or being able to implement these interventions within the public health system, and really thinking about implementation science as well as product development as ultimate goals for moving things out of just efficacy trials, but really getting them out and into the world. So with that, I'm going to pass this on to Tamid for some other comments about where we are and where we may be going. Tamid.
Yes, thank you very much, Jad. We have been listening, to the fascinating presentations, and it is clear that one of the key factors behind the increased suffering and the excess mortality of children suffering from acute malnutrition is the fractured health system, the inadequacy of health systems that we see in most of the countries. And this has been so adequately painted by Ezekiel, Salim, and Hama. But should we then stop there and not do anything? I don't think so. And CHAIN, I think at this stage, provides answers to several questions that will help us in finding solutions. The first question is, when do severely malnourished children, when they are acutely ill, when do they die? And we have seen from the presentations that 50% of all such deaths take place after they are discharged at home. So certainly we need to find out something based on the results from CHAIN about whether such interventions are to be based on something related to nutritional support, whether we need to transfer these children to an outpost. For example, in case of Bangladesh, we have the community clinics that are spread out all across Bangladesh. And we might also think about some other intervention. For example, early recognition of the danger signs. The second question to which I find an answer from CHAIN is, why do these children die? And again, we have seen from the data presented today, nutritional status is an important element. From other work done under the umbrella of CHAIN, we have seen other things. For instance, the disorder of the mitochondria, and also the problems that we see with systemic inflammation. It seems that systemic inflammation is there, ever pervasive. So we need to think about new interventions, perhaps to offset this huge degree of systemic inflammation. I wish we had something to deal with the disordered mitochondrial dysfunction that we have seen in these children. The third question to which I think we have an answer from CHAIN is, how can we prevent children from progressing to this florid form of acute malnutrition, severe acute malnutrition in its extreme form? And we have seen again the gradient of nutritional status in, perpetuating the morbidity and also increasing the mortality. And over the last years, we have seen many interventions come up, and these interventions are mostly nutritional in nature. Now it is time to see how we can fine-tune these interventions with some of the knowledge that comes out of science that has been done very recently. For example, the science that allows us to look at the gut microbiota and to modulate it so that we have new novel interventions to take care of children with acute malnutrition. I think these are some of the very excellent things that we see coming out of CHAIN. And in the next several years that follow, I think we need to bank on this and come up with new interventions so that we can save these children. Thank you.
Thanks, Tammy. Thanks, Judd. We're going to pause just for a moment and go back to Emmy and the audience poll. So, Emmy, maybe you can just join us now and give us a little bit of feedback.
Thanks. So we'll ask you to respond to the same two questions that we posed to you at the beginning. So the first question being, do well-nourished children have an increased risk of dying after hospital discharge compared to children in the community? Please answer one of the four options. A, yes, they have a lot higher risk of dying. B, yes, they have a slightly higher risk of dying. C, no, they have a similar risk of dying. And D, they have a lower risk of dying. Move on to the second poll question. The second poll question says, how long does an increased risk of dying amongst malnourished children after hospital discharge last? Option A, 2 weeks. Option B, 4 weeks. Option C, 6 weeks. And option D, at least 6 months. Great. I hope that we've all had a chance to respond to the questions. I'll now hand over back to Nigel, and hopefully we'll be able to see what our answers have been now. Thank you.
Good. Thanks there, Emmy. Well, I'm actually going to hand over to Judd because I think there was a hope to get a short period of discussion. And I would encourage you, if you haven't already looked at the Q&A, that there have been 12 questions submitted. And Kirk has been busy in the background answering many of those questions along with Jay. But Judd, over to you just for this last portion of the webinar.
Wonderful, thank you so much. And I'm going to really ask that we have you, Nigel, and also Beatrice Amadi, who's joined us and was introduced earlier. The two of you, I would love to hear your reflections of having heard this and how it both fits into and integrates with the work that you're currently doing and where you see the future directions of this leading. So maybe we'll start, Beatrice, if you're with us, maybe we could have you start and give some comments.
Yes, so first and foremost, I want to congratulate the CHAIN team for this very, very important study that they've carried out. And the fact that it was multi-center gives a lot of strength to it. And also that the findings are similar across sub-Saharan Africa and Asia. And I just want to pick on one of the things that Jay said about health workers and families viewing the children as having recovered at the time of discharge. I think this is what most of the parents, even the health workers, I can imagine the doctor on the ward round comes to this child and then examines and then writes and says, oh, discharge home, maybe review after 1 month, and gives the paper to the mother. And this mother goes away and then thinking, oh, she has to come back to hospital like after a month or after 2 weeks, whenever this review is going to be. But there's much more to that. I think some of the things Tamid has touched on them. From my own experience as well, and the area where I work, I look at gut inflammation. We know that, and it's documented, that these children with severe acute malnutrition, even just the undernourished one, most of them actually come to us, even though they come with severe acute malnutrition, it's against the background of chronic malnutrition, environmental enteropathy, malnutrition enteropathy, HIV enteropathy, and then enteropathy due to some other infections that they have with bacterial translocation. Does this clear at the time of discharge? We don't know. The fact that we put this child on antibiotics treated, the child has a good appetite now and is gaining weight, does it mean everything else is okay? The other aspect of it is, which I've grappled with myself in my practice, is that this mother brings a very sick child to me with severe acute malnutrition, with sepsis, or maybe there's pneumonia, maybe underlying HIV. I manage this child very well, and I feel that I've established a good rapport with the mother. And the time she's going home, she's a happy mother. The child is smiling, or maybe even has attained the lost milestones. And yet when she goes home, this child becomes ill. She doesn't come back to me. I mean, there are so many other factors that have been alluded to here. Could be also financial. It could be maybe the husband doesn't give permission or whatever, but I still wonder why this mother, who spent maybe a month in hospital with her child and got the child better, the child starts developing edema of feet, or maybe develops diarrhea, she doesn't come back, and the child dies in the home. And over the years, I've come across such a very saddening situation that a child dies. This mother already had this route to me, and she could come, and I even said to her, if you see anything, you come back. But she doesn't come, and the child dies in the house. I'm a very great fan of IMCI, Integrated Management of Childhood Illnesses. And what I liked best about it was the fact that there was counseling of the caregiver. At the time, even the time of interaction and the time of managing this child. And more importantly, it's the issue of when to return. There's when to return immediately and when to return for a scheduled review. So in IMCI, this caregiver is told, if your child has vomiting, everything, danger signs, or if a child has develops more diarrhea or has difficulties breathing, bring the child immediately. But that is in primary health care. We somehow haven't pushed that into the inpatient care. So there the doctor just writes discharged, and these are the medication, and go home, come after 2 weeks. And then also what else is said to this mother at the time of discharge? So those are the kind of things that I'm looking at. And then I also look at children with disability. I don't know in other African countries or in Bangladesh, Pakistan, but of late, we've tended to see a lot of children with cerebral palsy, with hydrocephalus. We grade and assess these children just like any other child. One time I was sitting in the emergency room, comes in a mother with an 8-month-old child with hydrocephalus. And she's been going for monthly weights. And the weight was going up so much And I asked her, did they say anything to you? She said, no, reassured me that your child is doing very well, is gaining weight. But that weight gain is because of the increasing head size and the fluid in the head. That's why. On the other side, we have children with cerebral palsy who have feeding problems. They come with severe acute malnutrition. Some of them can't even take, like solid foods, even a porridge, they won't be able to take. In hospital, we feed them via nasogastric tube. When they go home, we don't have any programs. So again, it brings me to what Zufi said about outreach and community management. We need to look at this. And also, when I look at the chain study, one important thing I've noted from there again is that, yes, we weigh children, and as pediatricians, we're very much occupied with weighing children, maybe because we need to calculate the dosage of drugs. We need to tell the mother, oh, your child has gained weight while in hospital or has lost weight in hospital. But most of the time, the equipment is obsolete, some of them. I went to, I won't mention the country, but the country I visited to go and do training in management of severe acute malnutrition, they were still using the UNICEF hanging scales in the ward. So I asked them, what if a child comes in who is very ill? How are you going to measure? So we don't have, and it's just not available. And where you have the mother-child scale, you don't have batteries. Yeah. But here in the chain study, they were using mid-upper arm circumference and the DIMA checks. And we're able to say these are high risk and these are low risk. We can discharge them earlier. This one we can keep longer, and this is what we need to do. So we can do anthropometry and put it to good use, not because we are going to calculate the dosage of drugs, but it's also assessing. In my hospital, the only children who get assessed further based on anthropometry are those who present with severe acute malnutrition. Moderate acute, any other child, yes, this is the weight, or it's underweight, and that's it. So I think those are the points that I have. Yeah.
Thank you so much, Beatrice. Really insightful, and thanks. And I think linking that to your personal experience was really, really valuable. Thank you. Yeah. Nigel, I'm going to hand this over to you for some closing comments as well, if you can wrap your comments together, and we'll finish up in the next 4 minutes or so. But thank you very much, both of you, for participating. Nigel, to you.
Thank you. Well, I think just leaves for me to say, both as a clinician and also someone working at WHO, how fantastic it is to see this work going on. I'm not part of the Chain family. I'm kind of a cousin, second removed, being part of the advisory group, but it is fantastic to see this work progress. Mainly because, in 2013, one of the WHO guidelines noted that just the extent of research questions and evidence gaps. And Chain is really addressing those gaps in a really serious, robust way. And that's wonderfully gratifying to see. I think we see in Chain both the combination of the epi, the interventions, the social, as well as some of the much more in-depth laboratory type investigations, which really make it a comprehensive and coherent evidence base that will really help us in thinking about guidelines and interventions for the future. So that's really great. And as Tammy pointed out, we're learning about some of the health systems issues that remain a real challenge for us. And we're also learning about the interventions that we know work. But we're also seeing now new areas of understanding and insight, and pointing us to a different set of and type of interventions being required. So it's not an either or. I think all of these things need to be addressed. So really, just in closing, I want to thank everybody for participation in the webinar, especially to all the speakers. We've received many comments and your questions, and we'll put these together. And I think all the questions were answered, but if you have more, please share them with us. The recording of this session, along with additional materials, will be shared. The link to where you will be able to find these will be put in the chat. I'm hoping, there we go, just as I said. So look out for that. Share the link with colleagues, people who haven't been able to make it. And really just for me to close by really thanking the superb dedication and expertise of all the Chain investigators in every part of the sort of the chain network. Also to the Gates Foundation for supporting and having the vision to put the investment into this. And we look forward immensely to some of the intervention studies and the findings from that that will be based on the finding. So thank you, Judd and Jay, for inviting me to participate. It's been a real honor. And thanks again to everybody. All the best.